All right, hello everyone. I'm Dr. Carol Clark, President of the International Institute of Clinical Sexology, and I'm delighted to be hosting today's oral defense with Suzanne Mulvehill defending her dissertation. What we're going to do is Suzanne will be able to share her screen in a moment and give her presentation. Then we'll open it up to questions. And then her chair, Dr. Batista, will sing us out. So, without further ado, Dr. Mulvehill, if you not yet, sorry, jumped the gun there.
Thank you. I'll go ahead and share my screen. Okay. Thank you. Okay.
Is it allowing you? Yes.
Okay. And here we go. Okay, let's make it larger. Okay, here we go. Hi, everyone. Thank you for being here. Thank you, Dr. Clark. I'd like to introduce the title of my research, Cannabis for the Management of Female Orgasmic Difficulty Disorder, FOD, an Observational Study, and introduce my committee and thank them immensely. Dr. Malin Batista, my chair, with IICS, Dr. Jordan Tischler, a cannabis specialist and Harvard medical doctor, and Dr. Becky Lynn, an OBGYN who conducted a cannabis and a sex study in 2019. That was a foundational study for my research, finding that women who use cannabis more frequently were twice as likely to orgasm. So the reason for my research was really a personal inquiry on these two topics, and I'd like to introduce the problem statement. FOD is a public health problem affecting a high percentage of women with a paucity of treatments. While 50 years of cannabis and sex research reveals cannabis helps women orgasm, no studies have evaluated cannabis and FOD. The support for the problem statement is that up to 41% of women worldwide experience FOD, and this is an unchanged statistic for 50 years. Directed masturbation is the only empirically validated treatment, and that treatment is only for women who have lifelong FOD, which is when a woman has not yet been able to orgasm in her life. There are no validated treatments for acquired FOD, which is FOD that happens after a woman has been able to orgasm and cannot any longer, or situational FOD, which happens in certain situations or with certain partners. And cannabis has been recommended to treat FOD and other sexual disorders for decades. You can see back in the 70s, there were several studies here that are highlighted where it was recommended, and most recently by Amanda Moser in January of 2023. So I'd like to give you the statement of purpose for this study was to evaluate what effect, if any, cannabis had on women who had FOD during partnered sex. And just going into a little bit of the endocannabinoid system and THC before we go into the theoretical framework, because these components play a role in the theoretical framework. The endocannabinoid system, which is within the human body, regulates sexual behavior. And tetrahydrocannabinol, THC, the psychoactive ingredient in cannabis, produces many of its psychoactive effects by engaging the CB1 cannabinoid receptor. THC stimulates neurons in the brain's reward system and plays a role in the experience of sexual pleasure. And it reduces activity in the prefrontal cortex, which is the higher functioning, and the amygdala, both of which are important to sexual functioning. And you'll hear a little more about that in the theoretical framework. So there's 4 theories that support a hypothesis that cannabis may help women orgasm who have lifelong acquired or situational FOD. The first one is the dishabituation theory by Drew and Miller in 1974, that THC causes a dishabituating effect, that information processing at higher brain structures under the influence of THC reduces routines that are represented by habits. And one of the habits, the rationale for this theory is one of the habits that women have is cognitive distraction, which causes a reduction in the ability to have an orgasm. It's coordinated or correlated with FOD. And this can introduce novel experiences, which would be a reason why a woman who has never been able to orgasm could orgasm when using cannabis before sex. The neuroplasticity theory proposes that cannabis and the endocannabinoids are increasingly recognized for their roles in neural development processes, which include brain cell growth and neuroplasticity, which is the rewiring of the brain or developing a new neural pathway. And this theory can explain why it was found in some anecdotal research, some women that have learned to orgasm with cannabis don't need it after a while because the neural pathways have been established. The third theoretical framework theory is the multimodal treatment theory, which proposes that cannabis, with its more than 100 different phytocannabinoids and more than 400 chemicals, it can treat multiple symptoms and conditions simultaneously. This was found, the rationale for this theory was found in the Casman 2020 study that found that regardless of the reason that women used cannabis, that female sexual function dysfunction declined. The amygdala reduction theory proposes that low doses of THC can reduce threat-related amygdala activation and modulate threat-related processing in trauma-exposed individuals and women, and that hypervigilance, anxiety, and post-traumatic stress are responses of the amygdala, and they commonly impair sexual response. And a study by a researcher named Koshiba in 2019 postulated that a reduction in anxiety can actually improve the opportunity to have an orgasm and overall sexual experience. The research questions for this study there's 4 of them. Does cannabis help women orgasm who report FOD? Does it help women enhance the intensity, frequency, or quality of their orgasm? Does cannabis, when it's used before sex, help women orgasm who report FOD? And does it help lifelong, acquired, and/or situational FOD? The methodology for this study was that it was an observational study with a sequential mixed method approach with 2 phases. Phase 1 was a quantitative study with a 41 question Qualtrics online survey posted through social media primarily. And it had 2 design criteria. The first one was a within subjects design, and this was accomplished through the Female Sexual Function Index orgasm subscale questions. That index it's a validated survey that has 19 questions, and 3 of those questions pertain to orgasm frequency, orgasm ease, and orgasm satisfaction. So women were their own control group because we analyzed with and without cannabis use to the response to those 3 questions. The cross-sectional design was accomplished through this study being conducted and capturing data in 1 period of time. Phase 2, the qualitative, the interviews were done with semi-structured questions were designed based on the results of the quantitative to go into a little more depth using grounded theory, content analysis, and thematic analysis. The sample and the data sources, the inclusion criteria for this study were women who were at least 18 years of age. They had partnered sex and cannabis use within the last 30 days, and they were born with female genitalia. The exclusion criteria, which was the use of other recreational studies within the last 30 days, pregnancy or breastfeeding, and in the data cleaning period, we removed women who had never used cannabis before sex. They were able to complete the study, but we found that they weren't able to answer the questions because they never used cannabis before sex. The quantitative data was conducted with 2 types of analysis, statistical analysis and comparative analysis. The statistical analysis had 2 groups of women with FOD and all women, which were women with and without FOD. And comparative analysis was women with FOD and women without FOD. The primary null hypothesis for this study was that cannabis will not have an effect on orgasm. And continuing here, we evaluated paired and unpaired response to orgasm response with and without cannabis. So inferential and descriptive statistical methods were used, parametric and non-parametric tests. And here you can see the 5 different statistical methods that were used: McNemer test, 1 sample t-test, 2 keys HSD, t-test, and f-test. And the findings, there were 1,037 survey responses over a 6-month period, 387 valid and completed surveys, 52% reported FOD during partnered sex, and 77% of those women, 155 out of the 202, reported no other sexual difficulties besides FOD. The main findings for this study were for women who reported FOD during partnered sex and used cannabis before sex was increased orgasm frequency, increased orgasm ease, and increased orgasm satisfaction, all with a p-value less than 0.001. We'll go through 3 of the figures that pertain to those 3 areas. Orgasm frequency. If you notice here in this figure on the far left, with cannabis, the largest group of women with cannabis reported almost always orgasming when using cannabis before sex, while the far right, the lighter blue, which is without cannabis, the largest group of women reported almost never or never orgasming without cannabis. Orgasm difficulty, the largest groups of women, there's 2 with cannabis, reported it not being difficult or being slightly difficult to orgasm when using cannabis before sex, where without cannabis before sex, the largest group of women reported it being difficult to orgasm, with the second largest group reporting it being extremely difficult or impossible. For orgasm satisfaction, the largest group of women with cannabis on the far left, you can see reported being very satisfied, which is about 40% of the women, whereas without cannabis, the largest group of women reported moderately dissatisfied when not using cannabis before sex. Secondary outcomes, there were 3 groups of secondary outcomes. The first group pertained to, and these were secondary outcomes with statistically significant p-values. So for women with FOD, which was the group of 202 women, partnered sex frequency, women who used cannabis more frequently and had partnered sex more frequently had a more positive orgasm response. Women with FOD and all women, so both groups of the women, we had p-values that were statistically significant for the frequency of cannabis use before partnered sex. Both of those groups had a p-value of less than 0.001. While reasons for cannabis use, they were different p-values, yet both of them were statistically significant for why they were using cannabis before sex. And the reasons for use for women who had orgasm difficulty, the reasons for pain and the reason for sex were the 2 that produced the most positive orgasm response. For all women, and this did not apply then to women who had FOD, just for the largest group of 387, including both women with and without orgasm difficulty, primary intake method, mental health diagnosis, and sexual abuse history were all statistically significant. These were interesting findings, not statistically significant, however, interesting that prescription drug use did not impact orgasm response for women with FOD or for all women, which is unusual, not unusual, but I mean, typically prescription drug use, SSRIs, for example, can actually cause acquired FOD. So this was an interesting finding. And the length of time using cannabis before sex was not statistically significant for women who reported FOD. This meant that women, if they used cannabis for less than a year or they used cannabis for 5 years or more, it didn't have an effect on their orgasm response. The findings that had no statistical significance, the variables included for women with FOD, included the demographics of age, race, income, education, sexual orientation, religion, relationship status, sexual relationship status, masturbation frequency, and relationship satisfaction. So these did not have any statistical significance in the study. And the comparative analysis found something interesting with regards to women who reported FOD compared to women who did not have FOD. Here you can see that 52.6% more women, more post-traumatic stress disorders than women without FOD, more sexual abuse histories, more depressive disorders, mental health issues, prescription drug use, and anxiety disorders for women who had FOD compared to women who did not. On the qualitative side, there were 20 women interviewed with FOD and 20 women without. And these women had all given their contact information in the survey. So here you'll find in the largest group of women had an immediate to a few weeks noticing a response on their orgasm, while the second largest group, it took them 6 months to 1 year. So this is just good information for us in terms of designing a future study of how long does it actually take. No studies have really looked at that in the past. And I'd like to look at the far right of experimenting and no orgasm yet. And we'll go into a little more detail of these two women, some highlights of these two women who have not orgasmed yet, even though they're using cannabis before sex. The first woman you see is 35 to 44 years of age. She's used cannabis one time before sex with a partner, uses it in general a few times a year. She masturbates 2 to 3 times a week, and she orgasms, but she's not able to have an orgasm during partnered sex. Woman number 2, 25 to 34 years old, does not masturbate, has a sexual abuse history. She's used cannabis for 1 to 3 years, and she uses it most times before sex, yet she has not yet had an orgasm with or without a partner. So both of these there's variations in their experiences. However, it's kind of going down a little bit deeper into the research. So we'll look at some findings of the mixed method. I collected data in the survey of women were able to add additional comments, and also in the actual interview. So this also answers some of the questions with regards to the research question. So women who had lifelong FOD who learned to orgasm with cannabis. This woman said, I knew something was off as I was not able to orgasm from masturbation either. I was raped in my late teens. I told the guy I was dating, who is now my husband, about my sex abuse history. And he said, try this, cannabis, and it worked the first time. And this comment was in the survey. You asked about the last month's use, but I want you to know that before using cannabis, I had never, and she highlighted that, she made that in capital letters, she'd never had an orgasm. For acquired, this was a woman I interviewed who had had a hysterectomy and had lost the ability to orgasm for about 2.5 years. She said, the third surgery changed the shape of my vagina. Intercourse became painful because of the way the muscle was stitched, and it took several surgeries to get it fixed. I heard the cannabis could help and started using it. I went through a trial and error period of about 6 months, and eventually got my orgasm back. So here's a woman with acquired, and then situational. Two women here. It might be relevant to know that cannabis not only helps my ability to orgasm, but also makes the orgasm more intense and pleasurable, which answers one of the research questions about intensity and enjoyment. And the second comment, I always orgasm every time I have partnered sex, but generally find it difficult to do so. I can only orgasm in certain situations, and rather than increasing the number of times I orgasm, since I already orgasm regardless, cannabis allows me to orgasm in other situations. And that was found where women would comment about being able to orgasm from penetration only with cannabis, or during with oral sex in different ways. Leading up to the limitations and delimitations, some of which we've already discussed. Cannabis use before sex did not help all women orgasm. And one woman had commented, it's not a magic pill. 3% reported never having had an orgasm. The results may not be generalizable to women who rarely or do not use cannabis before sex, never had an orgasm, or recently became sexually active. And the cultivar of cannabis and the chemotype were not evaluated. The significance of the findings, this is the first study to dichotomize women with and without FOD and evaluate cannabis and FOD. This study adds to and supports the 50-year body of cannabis and sex research, and finding that in the study that cannabis helped lifelong, acquired, and situational FOD. Lifelong and acquired were basically through the anecdotal findings, where situational during partnered sex we heard about through the orgasm frequency orgasm ease and orgasm satisfaction were statistically significant. And cannabis use before sex resulted in more orgasms for sexual abuse survivors and women with a mental health diagnosis. The recommendations: randomized controlled studies are now needed, as well as additional studies to evaluate dosage, timing, and FOD subtypes. And hopefully this research will contribute to doing these types of studies. Petition US states and countries to add FOD as a condition of treatment for medical cannabis. I've already petitioned New Mexico, and they're going to be discussing it on December 4th at their meeting, with letters of support from 2 medical doctors, Dr. Tischler being one of them, and Dr. Maureen Wieland in Florida being another one, and facilitate cannabis becoming a sexual medicine for treating FOD. So that concludes my presentation. I would like to thank everyone for listening and invite questions, and thank you.
I have a question. Can
Sure.
you hear me?
Yeah.
Okay. Yeah, Nan Wise here. You know, one of the issues that I have is when people are asking what kind of marijuana to use. In terms of the recommendations, I think it would be helpful if we could actually get some empirical evidence as to what kind of terpenes or chemivars or whatever you call it would be useful. So that's always an issue practically.
I can just comment on, in the interviews, women commented on the preferred strains, but there really wasn't any empirical basis for it. It was just, oh, I like this one or I like that one, without really, so I agree with you. That would be a really great study to conduct.
And one thing is, I don't know that much about this, but the terpenes apparently, like, for example, there's some that are associated with anxiety reduction. So maybe we can drill down when people are talking about strains, that they can get information on what particular type of terpenes that might be predominant in that strain. And I have one thing to say about the amygdala. So in my research, the brain correlates of orgasm in women, we saw strong activations of the amygdala at right around and during orgasm. And we need to kind of update. First of all, I think the way we can think of the amygdalas is they really encode intensity. So it's like very, very bad things and very good things. Kind of like the amygdala pokes at the hippocampus and says, pay attention to this. So what I'm saying is I think the amygdala gets a bad rap for just being about fear and pain and all that sort of thing. The amygdala definitely goes online quite impressively with orgasm. So, and wonderful job. Congratulations.
Thank you, Dr. Weiss. Nice surprise seeing you here. Thank you.
My pleasure.
May I make a comment on the subject of cannabinoids, terpenes, and strains? I don't know whether this is an appropriate bit of conversation for this forum, but I would say that in my experience, there is far more interest in these strains and the differentiation between them in the cannabis industry than is supported by data. And there is a very strong placebo effect involved. Nobody goes and picks up some cannabis without being told what it is, right? Oh, this is a sativa. Oh, this is great for this or that. And so there's a lot of that sort of bias involved. Clinically, my experience has been that if we can move past that bit of discussion, we've seen really no indication that there's any medical outcomes that can be attributed to the strain choice. And that mostly the strain discussion ends up being marketing hype. I don't doubt for a minute that there may be effects of various terpenes and cannabinoids that are more specific, but I think that that will come into play much more at sort of a pharmaceutical level of recombination than what we're seeing in terms of the differences between these strains. almost all strains contain nearly identical amounts of nearly identical cannabinoids and terpenes. There are minor variations, but they're very small, and at least clinically don't appear to have the effect that is discussed so widely.
Awesome. Thank you so much. Peace, you had your hand up?
Dr. Tischler talked about that. I've come across, I'll put it in the chat, I've come across this product at one of our dispensaries that I own, and a lot of it I think is placebo. Nobody's really studied this. They just can label it as, oh, this is great for pre-sex cannabis, but there's no study that's been done on it. So there could be a great extension of your research for somebody else to pick up and try to formulate something that is, like Dr. Tischler said, gone through the process of saying, yes, there are terpenes that affect this, or it doesn't really matter.
I would also say that the product that you just put in the chat box, in addition to not just being a cannabis product, but it is a cannabis with other supplements added, has two issues as far as I'm concerned clinically. One of which is, not only do we not know all the details about the cannabis aspect, but oftentimes these additives are not well understood themselves. And this particular brand, 1906, is a brand that formulated a nighttime version that contained a toxic element that made people sick in Massachusetts and in Colorado. And subsequently, they have reformulated their product, but frankly, it just kind of soured me to these kind of cannabis plus other stuff preparations. And then the other point I would make is that, in soon-to-be Dr. Mulvehill's research, we confirmed that most of the beneficial use was in fact via inhalation, which it confirms my clinical experience that, things taken by mouth, because there is a long delay to onset, make it very difficult to get a reliable and timely sexual response, particularly in a partnered situation. And so that while I don't recommend that people smoke because of the smoke, there are other safer approaches to inhalation that then get a more rapid response and are more easily coordinated in both a solo and partnered situation.
Other questions, comments? So it seems like, is there some potential then, since female orgasmic disorder is a diagnosable disorder, can cannabis be prescribed for it? Yeah, anytime now. If I go into a dispensary, I get my doctor.
The regulations vary from state to state, but there is no state that currently lists FOD as a specific treatment or a specific what they call qualifying condition. And that was sort of what Suzanne was talking about in terms of starting to petition New Mexico and Connecticut and a few others. Some of the other states like Massachusetts, for example, uses these qualifying conditions sort of more as examples of the intention rather than an ironclad list. And therefore, I have been able to include female sexual dysfunction as well as any other sort of sexual issue in my clinic. But it's and the interesting thing that you also touched on is the idea of prescription, which at least in the traditional sort of pharmacy/pharmaceutical realm is much more of a precise instrument than what we have at the moment in the cannabis world, which is sort of like, you can tell people what they need to get, but then when they go to the store, they can get anything they want, and they are often talked into a whole bunch of products by the sales associates. And so, we're sort of suffering from that sort of loose situation at the moment. And ultimately, my hope is that we will tighten that up a little bit so patients get better outcomes.
Thank you. Somebody put a question in the chat. Given the cannabis use seems to provide a benefit, were there any potential downsides or anyone reporting negative effects? Unmute.
May I stop sharing the screen?
Sure.
Okay. One of the things that was, may I ask who asked the question? I didn't see who.
AS or ASs.
Yes. Okay. But yes, dosage is something that really there were several studies done that had shown that it had a negative effect or inhibited orgasm. And in those studies, dosage was not evaluated. The women who were interviewed, like that's really, I think, where I drew the depth of the research from the women that I interviewed. They knew how much to use. They knew whether it was one hit, whether it was from 1/4 of a homemade brownie to I share a joint with my partner. Some women found that it didn't help them orgasm. They became, it actually deterred their orgasm if they used too much, or as we heard, there were 2 women it didn't have any effect on. So, there was a book back from the 50s where I'm trying to think of the author of that, where he said you have to learn how, it's something that has to be learned. Becker is his name. How to Become a Marijuana User was his book back from the 1950s. And he talked about if people cannot find the enjoyment in it, they're not going to use it. So, I had an anxiety attack the first time I used it in college and didn't use it for another 40 years. Like it wasn't ever on my list of things to do. It was, in fact, something that was not on my list to do. If anything else, it was a no for me. So I don't know if that answers the question that was asked. You're welcome to. But it's not a magic pill. And I think that was a comment that a woman made in the study, in the interviews that I did. She said, this is not a magic pill. This is not something you just take, it's taken with consciousness. I mean, when you look at it from a medical, this is about from a medical perspective, versus just a recreational, getting high kind of thing. It has a woman that I interviewed I'm not going to say where, but she had talked about how, how it was, she could calm the mental walls. That's what the sexual abuse survivors talked about, how their mental walls were able to come down and they had safety. They were choosing safe partners to be with.
I would just add that even with inhalation, it's quite possible to focus on and be reasonably precise with dosing. And that we have sort of currently amongst the many levels of stigma involved in cannabis, this idea that there's sort of no accounting for dose and that people just use too much and whatever. And unfortunately, many people do use too much. But in the clinical setting, it is quite possible to focus on and be precise about dose, which then allows us to be able to say to a woman or to any patient, not only do you need this type of product that you will use this way, but this is how much you should use. And typically I would specify a relatively narrow range so that she or he can go and start at the lowest end of that parameter and then do that learning without kind of rocketing off into the stratosphere and getting into trouble. In the cannabis industry, there is this sort of mantra, start low and go slow. And, I think that's cute slogan and whatnot, but the problem with it is that while it's a good piece of advice for where to start, I guess, it depends on if you know what low really means, but the thing is there's no upper bound either. right? And so all of the people in the universe who have cannabis use disorder certainly started low and went slow. They just didn't stop, right? And at some point, with enough ingestion, then you start to create dependence from downregulation of the CB receptors that Suzanne had mentioned. And at some point, you get this kind of accelerating cascade. But that only happens if you're really out on that far tail. And if you're doing this, as she mentioned, in a medical fashion with attention to dose and timing, then those sorts of risks are really not on the table. And it's mostly then a matter of making sure that you have patient buy-in from the patient to stick within that necessary range. And the good news, at least in the sexual context, is the cannabis sort of becomes self-reinforcing in the sense that if you get too much, the stated goal of having better sex doesn't happen. And that's true in males as well as females.
Okay, other questions or comments? And everybody's gonna run off and like test this out.
I'd just like to say one thing as a sex therapist rather than a neuroscience researcher. It's a learning thing. So women who don't masturbate, they're not going to get the signal from the clitoris to the brains where we process sensations. So, you know, unless you're going to do the practice and you tune into the body channel, this is not going to work, generally speaking.
Absolutely. It is a facilitator, not a, effectuator. And you're absolutely right. And we didn't really get into this, but, clinically, I always start with solo practice so that people can learn what it feels like, both to use the medicine and the results of the medicine, long before you get into that partnered situation where there are added stressors and added, things going on and such like that. So you're absolutely right.
And I'll add comment here about what women had shared about in the interviews was the ability to focus on sensation. I mean, that came up over and over, and it was in the comments as well, where they can get out of their head. And they use that term, I mean, from a thematic perspective of they can get out of their head. But again, that has to do with the dosage piece, because it go over the dosage amount and it's like, don't touch me, kind of feeling where they don't, they're in their own experience. So it's having their own experience with their own relationship with the medicine.
Right. And I do want to jump in and say that in one of my studies, we showed that women just imagining pleasurable penetration, their brains look like they were having an orgasm. So it's not that we don't use the frontal regions, it's how we're using them. So if we're focused on the sensations or on our imaginations about sensations rather than the laundry, or are we going to have that orgasm, we can facilitate that sensation experience.
That's well said. And one of the philosophies, I'm sorry, go ahead, Dr. Clark.
Oh, Angela has her hand up, sorry.
Yeah, so very solid research, cool. So my question is not directly pointing to the research, but the number of women with FOD is huge, and you said it's largely unchanged since the 50s. Also, these women that you interviewed experienced positive effect with the use of cannabis. Why do you think this secret has not spread? Or now I label it a secret, maybe it's not, but what if this is working, why are the numbers not changing, you think?
Well, I think it's underground. What I found in the internet and on Facebook groups and in Reddit, which Reddit has 54 million people a day on Reddit. It's in the network that it is working. I'm using research from 2005 that talked about, that's like the latest the most valid recent study about the number of women that was done by Laumann, that team. But I can tell you in 2016, the team by Kontula and Mietinen, he is a Finnish, he's been studying female orgasm for 30 years. He had reported that the statistics haven't changed for 50 years. So he obviously analyzed that recently because that research was done in Finland in 2016/2018. So, my hope, my desire in basically getting it, this is a tangent of your question, is if we can get more awareness and normalize orgasm difficulty, then women are more likely to talk about it and make it a topic like they talk about other issues in their lives. I think hearing that they're going to take the word disorder off of PTS, so that post-traumatic stress, so that veterans don't have the stigma of the disorder. I was just reading about that yesterday. Taking the stigma off of female orgasmic disorder. They took it off for men. It's not called male orgasmic disorder anymore in the DSM-5. It's called delayed ejaculation. They did combine in the ICD-11, which I found very interesting. It's both genders. It's gender neutral for orgasmic dysfunction, but they still called it a dysfunction. And, I think looking at the high percentage of women who have like sexual abuse histories, especially from childhood, and how that's the number one sexual complaint of women who have sexual abuse histories is inability to orgasm. So it does, Dr. Weiss, you talked about from a neuroscience perspective, we don't know what actually happened in the brain of a child who got sexually molested, but for it to be an orgasm problem as the main sexual complaint, there is something that we haven't found out yet what actually happens to the brain when that gets shut down.
Thank you.
Welcome.
Okay, anyone else? Really outstanding work. I have to say, we went through it at the beginning, like how are you going to do this? And,
I know, I remember.
And I'm so glad that you pulled it off so
Thank you.
outstandingly. So, Dr. Batista. Oh, wait, Kat has something to say. Oh, she's clapping. Never mind.
Okay.
Okay, everybody's clapping. Yeah, I just see the little hand.
Thank you.
All right. Okay, everybody's applauding. Dr. Batista.
Well, Susan, I have a lot to say, but I can find words. That I know you put a lot of hard work into these for the past 4 years, right? 4 years. So
Yeah.
I congratulations on your tremendous success, your perseverance, hard work finally paid off, and I'm so happy. You now hold a doctorate degree in your hand. So congratulations, Dr. Mulvehill.
Thank you. Thank you very much.
Congratulations.
Thank you.
Congratulations.
Yeah.
Congratulations.
Okay.
So proud of you. This is awesome.
Here's to you, Doctor.
Thank
Suzanne.
you. Thank you.
5 o'clock somewhere.
Thank you. Thank you. Cheers. Some English breakfast tea.
Awesome. Thank you, everybody
Wow.
that helped, that supported you with this, and thank you.
Thank you.
We give credit to our institute.
Thank you all.
A
Nice
special,
kids here too.
a special thanks to the committed and all the beautiful, amazing teamwork that you had on these, Dr. Tischler and Dr. Weiss and the other doctors and everybody else in your family. I know, especially you, how much you put on this.
I had a lot of support. I did not do this alone. Like everyone that's here played a role in me getting this degree. So it's really our celebration. It's not just my celebration. Just every aspect of it. So it was, I shared with my kids, Chris and Melissa, who are here online, this was more work than I ever imagined. And it took longer than I ever thought. It was just, I had no idea what was involved in doing a dissertation. Like really, I used to think I continued to set goals about, okay, I'm going to have it done next week. And next week used to turn into 2 months or 3 months, or it was a long process. So,
Oh, this is the beginning. Oh, you
Yeah.
have a lot of work to do.
yeah, this is it. So I was accepted to speak. Dr. Tischler and I co-present in the World Conference for Sexual Medicine. Last week, I got an announcement that to do an oral presentation in Dubai
Nice.
in December 15th. Yeah, we have a date for that. So
Oh,
this is the
awesome.
beginning. Yeah,
Nice.
that was the footwork, what I did.
Okay, your son Chris direct messaged me, said, congrats, Dr. Mom, first doctor in the family.
Oh, yeah. Thank you. Thank you, Chris. Thank you. Yeah, it's true. Yeah,
So,
you can become
right,
one too.
send the bound copy of your dissertation to us, and we will send you your diploma and expect to see you in Miami for graduation in February.
Yay.
Thank you very much.
And we do have the date. I think it's February 18th. I'm pretty
Okay.
sure.
Okay.
So double check me on that, but we'll be sending out.
Okay, you can send that. Thank you.
So we'll
Very
look
good.
forward to seeing you and give you a big hug and
Thank
being
you.
able to hug you, and your kids can come and
Thank you. Thank
we'll
you
have a
very
nice
much.
celebration.
That sounds wonderful. Thank you very, very much. Thank you all.
All right, everyone.
Okay.
Go celebrate.
Yes.
Thank you, Melissa, too. Thank you. Okay.
Bye, everyone.
Thank you. Bye-bye.